Good afternoon, everyone. I want to thank you for attending this month's lecture. Dr. Douglas Johnson will be our speaker today.
All right, welcome everybody. If you don't know who I am, some of you do and some of you don't. Again, you can see that from the slide that my name is Douglas Johnson. I did my fellowship in cardiothoracic imaging at Wake Forest. It's been a little bit of time. It's been about 10 years now. And I currently work just outside of Charlotte in North Carolina, and that's I'm actually just finished up a minute ago to give this lecture. So I'm very excited to give this lecture because it is a rather difficult topic, and you can go through it a number of times and forget it just as quickly. So hopefully, if I go over a number of these things, some of it will stick. So this is a version of the lecture that I gave in Las Vegas last year. So here's my financial disclosure. So here we go. I want to first start with some basics, and yes, this is not the chest, but there's a point to why I want to start this way. And to use an analogy, when I was at Wake Forest spending a little bit of time with the body imagers and going over body MRI, the attending physician was talking to the residents and said that had asked why they were so afraid of body MR, because the anatomy is the same, and if you can remember all the anatomy and pathology, it doesn't really matter what it looks like. So what I wanted to do is just to do a short little exercise on some pattern stuff. And so high-res chest comes down to pattern, location, and history. And so when we take a look at this one slice of the abdomen, you can see that the abnormality is in the spleen. And high likelihood what this is, it's an infarct, because that's what it looks like. So many things in the chest follow the same thing. You just have to learn to know the patterns. The next thing here, some people may know this, some people may not, depending on how much cardiac imaging you've acquired in your training so far. But there's an abnormality sitting in the left ventricle, and this is a thrombus. That's what it is by location. That's where they grow. You know that it's not a myxoma because it has nothing to do with being in the atrium along the septum. You know that it's not a myxoma or rhabdomyoma, I mean not a myxoma, a rhabdomyoma or sarcoma, because it's not in the wall. You can see contrast completely around it, showing you the location within the chamber. So you've gone through the pattern and the location. Now this last one is, everybody knows the differential for something like this in the brain. The neuroradiology seems to be a lot more exciting than chest radiology, so you learn this typically in your first year, and you get to know the differential and how to use it. But it all depends on the history. Did the patient have HIV? Or did they have lymphoma? Have they had radiation? So it really kind of comes down to what's going on with the patient to help you narrow down the differential. High-res chest imaging is exactly the same way. You have patterns like that in the spleen. You have locations. Is it going to be in the upper lobes? Is it in the lower lobes? Or is it diffuse? And then you can correlate it with the history and find out what's going on. And then you can narrow down to the greater differential. So getting into high-res. Hopefully your eyes aren't glazing over by taking a look at this, because it is a busy diagram, but honestly this is the basis of all that is high-res. But if we could just focus on a couple of things and not have to worry about every little detail and all the words on this thing, if you get to know the very top thing, the normal secondary lobule. We're going to come back to this on a couple of different things, and you'll find out what kind of pathology this comes into. So if you get to know this, what the appearance and the construction of the normal secondary lobule, you'll pretty much nail down a lot of high-res chest. A couple other things that you want to take a look at is, what is it constructed of? You can see that the outline is what we call interlobular septal walls, or the interlobular septa. within the area through here within the actual lobule have septa within it, and so they're intralobular. So you have inter and then you have intra. So if you get to know those just couple of concepts without having to go through this entire slide, you'll really go very far in just finding out what's going on and what you can do for your clinicians in high-res imaging. Moving on to how we do it, just spending a second on this because a lot of people do it different ways. The ACR has certain criteria that they use as far as accreditation and things like that. I do a variation of it, and so one of the things you have to get to know is that you're really only sampling 10% of the lung. It's only 1 millimeter slice every 10, so you're not going to see everything, and you have to actually tell that to your clinicians who's inappropriately ordering it to get a really good look at that nodule. That's not exactly what it's for. This is for interstitial disease. Again, the non-contiguous nature of it, skipping every 9 millimeters. And as far as the position, I do it both in the supine and the prone, and you'll see that in many examples through the lecture that I do prone imaging, and it is very helpful in determining what's pathology and what's just compressed lung atelectasis. Breathing is difficult for patients because they're already coming in with difficulty breathing, so they do the best you can on that, but we try to have them breathe consistently through the entire exam, holding their breath in the same position, and they usually do a pretty decent job. Now, for first-time customers, as I call them, I do a low-dose spiral based on the lung cancer screening parameters, and I do the entire chest. The reason why I do that is it gives me a better idea of what's going on as far as zonal predominance through the chest, and it also gives me an out as far as taking a look at the whole lung when in internal medicine or other general doc orders it inappropriately, and they should have just gotten a low-dose chest, so I don't miss those nodules. Any future exams, I skip the low-dose spiral just to lower the radiation dose. And as far as radiation doses, I don't know if you all talk about that, but I've been the CT director at my facility for a number of years, and we're very attuned to the dosing, and you can see that I do a low DLP with all that, the prone supine and then the low dose imagings for a low millisievert of 2.6. Anyway, so what we're going to do is we're going to do a little bit of a pre-test. And because I figured that since we've been in school for years and years and years, we're very good test takers, but being able to make the jump to imaging can sometimes be a little bit difficult. So if you know the buzzwords, you guys can pick them out of a lineup pretty easily when it comes to multiple choice. So we're going to try to get used to what's going on and see if you can get those buzzwords to click when you're actually taking a look at an image. So first off, history. I look at, when I take a look at a CT of the chest, every single time I take a look at what kind of smoking history they have. It's very pertinent. So in this first question, we have a patient who has a 40-pack-year smoking history. Going to the imaging, some of the things that, if we imagine that there is an upper lobe distribution of small centrilobular ground glass nodules. So those two history points, or the history and the imaging points, can lead you to some things. So if I give you a couple of choices, respiratory bronchiolitis, interstitial lung disease, usual interstitial pneumonitis, acute hypersensitivity pneumonitis, or is it lymphangioliomyomatosis? So going through what you've got as far as the possible imaging, what kind of patterns you're looking at, and this comes up to be respiratory bronchiolitis, interstitial lung disease. The second one, we have, I got to move a couple of things out of the way. Okay, that's not moving out of the way. So anyway, so the history, we have abnormal pulmonary function tests. I'm not going to go into detail as far as anything like that. That's beyond the scope of the lecture. And the patient also complains of muscle weakness and a rash. Hold on, we got... There we go. Okay, now it's cued in. Now, the imaging findings on the CT is traction bronchiectasis, honeycombing, and a peripheral and basilar distribution. So, our choices. Is it going to be RB-ILD, usual interstitial pneumonitis, acute hypersensitivity pneumonitis, or the lymphangioliomyomatosis? So in this particular one, now we are looking for a pattern. We're not looking actually for the diagnosis. And so the pattern on this is usual interstitial pneumonitis. And I'll go in great detail later about what it is that I'm talking about and what the differential is. Pretest number 3, patient with worsening dry cough, dyspnea, and extensive hot tub exposure. The imaging is upper lobe central lobular ground glass opacities and air trapping. So here are the usual 4 that I've been talking about. And on this one's going to be acute hypersensitivity pneumonitis. Notice that in the previous slide with the imaging findings, it was very similar to the RB-ILD, and I'll go into that in greater detail. All right, the 4th one, the history is dysphagia, skin tightening, and blue fingertips. The imaging, traction bronchiectasis, honeycombing, and a peripheral and basilar distribution. Well, the imaging findings didn't change from the previous one, but the history did. So, but we're looking for a pattern, and the pattern, again, is usual interstitial pneumonitis. And that actually was a board topic about 5 years ago or something like that. So these do come into reality. So this last one, the pretest number 5, history is a 29-year-old white woman presents with a pneumothorax. The imaging findings are diffuse, thin-walled pulmonary cystic lesions. And the one that we haven't used to round out the pretest answers is lymphangioliomyomatosis. And at the very end of the lecture, I'll talk about that and one of the other things that accompany that. So, moving on to our first common diagnosis in high-res chest imaging, you can see here that I've got a couple images of high-res chest along windows, and this is sarcoid. And so what you can see here is that you have a mid-zone distribution, at least in the imaging that you can see, of these tiny little nodules. Where are these nodules? You can see them along the vessels, you can see them along the bronchi, you can see them along the major fissures that you can see. So they're kind of, to a certain degree, everywhere, but I would typically say that this is a peribronchial vascular distribution because you can see it just kind of branching out along the vessels in the bronchi. And so this is a typical bottle brush appearance of sarcoid. And as you know, I'm not saying anything new here, but sarcoid is common systemic granulomatous disease. But the thing is, I think I have about 6 or 7 different ways that sarcoid can actually pop up. It's a pretty common diagnosis that I make down here in the southeast. So I have lots of cool examples of what it can look like. You know that it hits multiple organ systems. One of the more interesting ones to me is the lacrimal gland. I always thought that was kind of fun. But it can have adenopathy with or without the pulmonary findings, and you know that that has different stages, but I honestly don't know if anybody actually uses those stages. We don't use it down here. But some of the findings that you do find in sarcoid are the reticular nodular type of things that we just saw. You can actually get much larger nodules getting into the 1 to 2 centimeter nodules. You can get ground glass opacities, which are extremely subtle, and fibrotic findings in more end-stage disease. So let's go take a look at a couple of different things. So we have a chest x-ray that you can see what's going on here. Got the arrows pointed out, the symmetric adenopathy. This is not to be confused with the asymmetric adenopathy that you typically get with lymphoma, that being the other major differential. So we've got a pretty wide right paratracheal stripe. You've got a pretty beefy right hilum, and then you've got a pretty beefy left hilum as well. So differential could be mediastinal adenopathy, but you can also think about some pulmonary hypertension, because on that left side you don't really know if it's going to be the pulmonary artery or something large in the AP window, because you know that on the left that the pulmonary artery sits right above or superior to the left main bronchus. So moving into the HRCT. So now, this is just a little board tip on this one. If you want to show a little bit of competence and confidence to your examiner, you can say that this is an HRCT in the prone position. Why would I say it's in the prone position? Because look at where the gantry is. I flip these images so the gantry is actually above the patient, so you know that this is actually a prone patient because you can't image him any other way with the gantry there. And so you can say that this is likely from a high-resolution exam and performed in the prone position. That'll catch their ear a fair amount just because they'll figure that you know what you're talking about. So going to the imaging findings, what you can see here is some subtle ground glass within the apices. You can see that we're pretty high up into the lungs here. Here we're at the level of the carina. And what you see besides the ground glass is the interlobular septal thickening. This goes back to what we were talking about as far as the secondary lobular unit. You can actually see the pathology outlining the different areas within the lungs here. So there's a differential to this, sarcoid being the one that we're talking about, but lymphangitic carcinomatosis and pulmonary edema can also have a similar appearance, but we're not looking at just one slice. So sorry about the phone call. Let's get rid of that. Anyway, so that's what's going on with this one. So you have the imaging findings from the chest X-ray, you have the imaging findings from the CT, and you have a pretty good confidence as far as naming this being sarcoid. So let's move on to another entity, another way to look at sarcoid. So, you know, in your upper lobe differential cassette P back in the primer that I used when I was a resident, there was a pretty long differential as far as what's going on, but this is what upper lobe sarcoid looks like. You can see that it has almost a honeycomb appearance, but this is actually a lot of bronchiectasis with not as much honeycombing, and it's hard to tell you what's going on in just one slice, but if you were to take a look at it in the coronal plane, it would really lay the whole situation out a little bit more. And a little bit lower, you can see that there's a lot of cystic spaces and bronchiectasis as well. And on the left side, you can see it a little bit less involved. This is a little lower in the same patient, and you get a fair amount of bronchiectasis. You can see extending out from the hilar regions bilaterally, a lot of the architectural distortion. So instead of having fine, lacy interlobular septal thickening and the ground glass appearance, this is completely different. This is more of an end stage or later stage sarcoid with all the bronchiectasis and cystic change. Now the other image, the mediastinal windows on this other slide, kind of outlines the adenopathy. Now I know that it's difficult sometimes in the early training. I used to really demand that contrast be used in CT of the chest when I was a resident because I couldn't really figure out exactly what was going on without the vessels in the lymph nodes lit up with contrast. But after looking at a number of these, you know, after 10 years, I feel more confident with being able to do it without contrast. So you can see that in the hilar regions over here, this is big and beefy. That can't be all vessel. You can see that over here is another lymph node within the subcarinal region. This is the esophagus with a dot of air in it, so you know that that's a lymph node over there, not the esophagus. This is the aorta, obviously, everybody knows that, but then this is actually quite too beefy as well. So you know that there's a fair amount of apathy in this patient to support the diagnosis of sarcoid. All right, another upper lobe sarcoid. Now this is kind of interesting because I have kind of a pre and post image on this one, and so what you can see here is that there's a decent cavitary lesion within the right up apex, and then you can see the other areas of bronchiectasis within the apices on the axial. So if we cut to 1 year later, you can see that there still is a fair amount of bronchiectasis. You can see the cavitation, but what happened in the right apex? Well, one of the things that happens in sarcoid when you get these cavitary things, and actually many kind of cavitary lesions within the lungs, things like to colonize that open space because they're immunocompromised. They can't deliver all the immunology cells in order to fight off infection and everything. And what happens is it gets colonized by Aspergillus. So this one year later, the sarcoid advanced a little bit, but got colonized by the Aspergillus within that cavitary lesion. All right. Moving on to another appearance. Here, again, upper lobe distribution. That's what you're going to run into most often. It's not very often predominantly in the lower lobes, but you can see that on the right image that there are tiny nodules pretty much everywhere. So having the history, some kind of clinical history, and some adenopathy would really help you narrow down exactly what's going on, because trust me, I have my, oh my God moments, and I have no idea what's going on. But when you buckle down and take a look at the individual findings, can try to find, areas of less involvement so you get a better idea of what's going on, you can kind of sort through all the findings. So this one is a little bit interesting because this is more of a ground glass appearance, and it's not nodular. So it's not the typical ground glass nodules that I showed you in a couple of cases. This is actually larger ground glass opacities, but it's not your typical appearance that you can just kind of wonder or blow off as nonspecific. This actually seems to have a little bit of structure to it. So, and this is kind of patchy in different areas of the lung, and I'll show you one more picture of it, that it's kind of, you can see it in the upper lobes, but you can also see it in the lower lobes as well, and this is a different kind of sarcoid called alveolar sarcoid. So you can see that not only is it multi-organ involvement, but it has a tremendous amount of variation in its appearance just within the lungs itself. So, and to finish it off, we have just the nodes only. I figured if I didn't have this in there, I would be missing, a major portion of what sarcoid can look like. So this has no, you can see by the right image that there's no pulmonary involvement, but you have the large lymph nodes on the mediastinal coronal image along the right paratracheal stripe, and you can see some of the lymph nodes calcified within the right hilum. So, moving on, got another entity to discuss now because we have a handful of them to go through. So this one looks completely different. We have two sets of images on this one. We have these axial windows, and then we have something a little bit lower. And getting to know where you are in the chest in the axial sense is a good way to discuss, what's going on, because it gives you an idea of where the location is. Just like I was talking about with the thrombus in the left ventricle, location is a big part of trying to down what's going on in high-res chest. So what I've given you is a mid and a lower lung. So I didn't even show you any kind of apices. So what we have here is a mess of bronchiectasis with some cystic changes and ground glass in the mid and lower lungs. What is this? This is usual interstitial pneumonitis. The most common cause of that is the idiopathic pulmonary fibrosis. This is one of the most common, unfortunately, this is one of the most common interstitial lung diseases, and I say unfortunately because it has the worst prognosis. The 5-year survival rate of this is about 43%, with the median life after diagnosis of about 2.5 to 3 years. So you can see that even though it's most common, it's not a fun one to get labeled with. And that's one of the biggest things to answer in high-res chest. One, is there interstitial disease at all? Because there's plenty of cases that I say that there's no interstitial lung disease at all. And if you answered yes to that, then you have to, your next question, is it usual interstitial pneumonitis, because that carries the worst prognosis. So jumping into this a little bit deeper, you can see the history there, progressive dyspnea and cough with restrictive PFTs. So what does it look like? The key finding is going to be the honeycombing. So you have a 95% positive predictive value if you see the honeycombing. We'll talk a little bit later of that 5% with another entity, but more often than not, as you can see, 95%. If you see that honeycombing, you've got a pretty much of a slam dunk UIP. Traction bronchiectasis is going to go along with it, and these can be variable. And I have different cases to show mild amounts and more severe amounts. The demographics of this disease is an older age group, the 55 to 70-year-old age group, where other entities have a younger age group, and you'll be able to see those in a little bit later. The lung volumes can vary a little bit. Typically with fibrosis, you're going to have a shrinking or lower lung volume, but sometimes you can actually have a pathologically normal lung volume. And the reason why I say it's pathologic is because you have the normal shrinking of the lung with the fibrosis, but you also have expansion of the lung with concomitant emphysematous changes, which is actually a new entity in the high-res literature that I won't really go into detail with because it's kind of new, and that's just the combined pulmonary emphysema and fibrosis picture. So where do we find it? You can see in the radiographics image in the red shaded areas that this has a basilar and subpleural distribution, and it can come with some ground glass as well. So if you have that in your mind as far as the terms, basilar and subpleural, you'll go a long way in being able to figure out what's going on. So here is some of the real imaging that were companion pictures with the radiographic cartoon there. You can see that there's a fair amount of honeycombing or cystic spaces along the with greater amounts along the pleural surfaces and in the basilar distribution. And the arrow, the thinner arrow over here points to some of the traction bronchiectasis. You can see that the bronchi go way too far out as far as their diameter getting to the level of the pleura out there, and I'll show you more cases of that. So what do we do with UIP? Because UIP is a pattern, and it's not unusual for me to have in my impression that interstitial change is consistent with a UIP pattern. A lot of times my dictation ends that way because basically I'm leaving it up to the clinician to find out why they have it, because there is a large laundry list of indications or diagnoses that have that same type of pattern. So you can see here, and being able to speak intelligently about it to your referring clinicians or to a board examiner and stuff like that, that these are the type of things that you would think about. I use, and if you could think about, what the mnemonic is, SHIP doctors. So SHIP is actual pulmonary findings of sarcoid or chronic hypersensitivity pneumonitis, IPF, or the pneumoconiosis. These are all pulmonary. Now, if you take a look at the doctors, the DRS, these are all connective tissue disorders because the collagen vascular disease has a very large component within high-res imaging. So you can see it with UIP, and you can also see it in NSIP, which I'll talk about in a little bit later. So, and I actually had a case of this when I was in boards, and I went out and had my dissertation on the whole possibilities of what was going on, but I had absolutely nothing to hang my hat on as far as any kind of imaging findings, and he wasn't going to give me any kind of history whatsoever, and I already went through saying it could have been sarcoid, it could have been chronic hypersensitivity pneumonitis if he had this, that, and the other kind of exposures, and pneumoconiosis and all these other things, and I ended up saying that he said final diagnosis, and I was crushed. And I was like, you're kidding, you're still killing me with this. And I threw out RA, which was wrong. And the reason why I was wrong is because the most common I should have fallen back to is the IPF. Anyway, so let's move on. So this case, here we have a fair amount, actually a huge amount of traction bronchiectasis. You have thick-walled cyst. You can see that the thick-walled cystic disease right up here. It's a little less down here as far as the posterior lung margins and everything like that. But one of the things that you can hang your hat as far as what's going on in this differential is the dilated esophagus, and this is a case of scleroderma. This next case is a little bit different, and I actually showed this in Dr. Rocky Sign's board review a number of years ago, just as a challenge case. I have easy cases and medium cases and then challenge cases, and this one was a little bit difficult because of the ramifications of what happens with fibrosis. So you have typical findings of the traction bronchiectasis. You have some mild honeycombing here, and you can see that you have the similar findings as well within volume loss of the right lower lobe. You can see the retraction of the major fissure, so that's indicating some volume loss because of the fibrosis. So this is a typical pattern of mild UIP, usual interstitial pneumonitis, but one of the things that's going on in this patient is because of the degree of inflammation, the cell turnover, and all that other stuff that happens, you have an opacity sitting in the right lower lobe. This was a lung cancer sitting in this patient, so you can always have more than one thing going on, and you just have to make sure that you hit all the possibilities. I think it's a 1 in 4 chance, or just a greater chance of getting lung cancer in these patients. Anyway, so one last image as far as UIP. This is a little bit different. Now, the imaging might not be a whole lot different because you still see a fair amount of traction bronchiectasis. You have a lot of honeycombing, but where are we? We are at the level of the left atrium. You can see that, that we're at the aortic root. We're at the left atrium. So where does that correspond to? That's the mid-lung. That's not basilar distribution. Well, this is a little variation in the differential, and this is chronic hypersensitivity pneumonitis, which gives the same findings of the honeycombing and the traction bronchiectasis, but this is actually a little bit, has a greater prevalence in the mid-lung. So I just thought I'd show you that for a little bit of differentiation. All right, switching gears. This is just a little bit of a break here. I had this case in the ER not too long ago. Pediatric patients have a hard time communicating with their physicians because they can't talk, but this one clearly was able to say that they were having a little bit of problem, and if you pay attention closely to the letters across his chest, here's the H-E-L-P, and the guy was screaming help, just basically on his chest as far as the chest x-ray. So I thought that was kind of fun. So anyway, moving into another entity. So this one is a little bit different. It's not as striking. You don't have big cystic spaces, but what you do have is you have a decent amount of ground glass. And you also have some pretty decent sized airways. Now, it can be subtle, but if you take a look at it and you compare it to the adjacent arteries, that you can see that they are a little bit big, and over here, being as close to the pleura as you are, the airway shouldn't be that big, so you do have some mild bronchiectasis. So in this entity, and I'll show you the prone images of this, that the ground glass did not go away, that this is going to be non-specific interstitial pneumonitis, and I'll tell you that in a little bit. But here are the areas of ground glass, the bronchiectasis. So here is non-specific interstitial pneumonitis. This is going to be a little bit different from the usual interstitial pneumonitis because this is going to be symmetric disease, and it's going to have a greater distribution. You can see that by the shaded area in the radiographics cartoon, that it actually is from top to bottom, but still in a subpleural distribution. You're going to get the traction bronchiectasis. You're going to see the ground glass opacities that we saw in the previous case. Reticular opacities are very, very common. And thin-walled cysts. Now, that's not to be confused with the thick-walled cysts that you'll see in honeycombing. There is a big difference between the two. Note the age distribution as well. These are younger patients. So these aren't going to be the older patients in the 55 to 70-year-old distribution. So that's going to help you as far as your history as well. So let's take a look at some of the other pictures that we have here. So one of the things that you can take a look at when you're getting a case, whether it's just out of the blue or you get a little bit of history as far as any kind of collagen vascular disease or something like that, or chronic lung disease, you can see that there's bronchiectasis. You have that signet ring sign where some of the airways are larger than their adjacent vessels. You can see the reticular changes and some of the thin-walled cystic changes along the periphery. One of the things you don't see is the layers upon layers of the thick-walled cysts, which is indicative of the honeycombing. this is a much less or a much more subtle case. You have the patchy ground glass, you have the bronchiectasis. So this might not be a slam dunk case for you, but at least you could start thinking about it once you see some of the bronchiectasis, that you kind of wonder if there's an interstitial lung component to this, and entertain NSIP in your differential. So this, the cellular and the fibrotic forms throw a little bit of a wrench into the positive predictive value for UIP with honeycombing, because there is a fibrotic form of non-specific interstitial pneumonitis, which is the 5%. That's the one that doesn't allow honeycombing to be 100% predictive. There is a fibrotic form that does have the traction bronchiectasis and throw in a little bit of honeycombing, and that makes it quite difficult to determine the difference between the two. And it's not unusual to, for me in my impression to say that there's bronchiectasis, there's these changes in the lungs. It's inconclusive or indeterminate as far as between UIP or NSIP. So that it's not a cop-out. It's actually common for the pulmonologist to get that, and because they know what to do with it. They know what else to dig for, to maybe do a bronch, maybe to do some other lab things, or dig into the history a little bit more, because what they want to ferret out is they want to know, is this a UIP because of the dire consequence of labeling somebody like that because of the median survival is so much lower. Now take a look in NSIP. The survival versus UIP is much, much greater. So if they can label this person with NSIP, they have a much longer lifespan after that. You can see the median survival after diagnosis is 13.5 years versus 2.5 to 3. In the diagnosis, the differential diagnosis is very similar as well. So sometimes that doesn't help as much, because in the differential diagnosis of NSIP is you have UIP, the hypersensitivity pneumonitis, which we already saw, sarcoid, the collagen vascular disease, and the drug toxicity. Some of the drugs that are involved in this are methotrexate, gold salts, amiodarone, different things like that that give you the fibrotic changes or the pulmonary toxicity, typically within the lower lobes. So you're going to see that both in UIP and NSIP. So hopefully I'm not muddying the waters so much, but just to emphasize the big point, honeycombing is the biggest positive predictive value sign that you're going to have to differentiate the two. So let's take a look at another case here. So just to kind of solidify what's going on, you can see the large airways. You can see them extending out to the pleura within the right middle lobe. That's way too far for bronchi to be visible like that. You can see that there's a fair amount of reticular markings along the periphery. Not so much as too many cystic lung spaces and stuff like that, but this is a path-confirmed NSIP case. This next patient was a patient that was well known to our department, and she came in with migratory rashes and persistent cough that just wasn't going away. And I told her to talk to one of our pulmonologists and get a high-res chest, and lo and behold, we have subtle findings of the reticular markings, some ground glass, some the mild bronchiectasis, and again, this was NSIP. This last case is a fibrotic form, so you can see that there is some difficulty in determining what is honeycombing, what is thin-walled cyst, and not being able to really nail down the differentiation of the pattern. The arrow is actually pointing to an area of subpleural sparing. Yeah, it's subtle. I completely understand that, but there are other subtle findings that you can find throughout the body, so chest is not excluded from some subtle findings. Sometimes you just got to go look for them. So here you have layer upon layer of cysts. You have retraction of the major fissure, and so this is pretty much indeterminate for UIP or NSIP. But one of the things that's going on here is you can see that there's a dilated esophagus. They've got a collagen vascular disease nonetheless, which occurs both UIP and NSIP, and that's scleroderma. So enough of that. So let's move into something else. This one is a little bit easier. So we have a single image through the mid-chest. You can see we're at the level of the carina, and you can see a fair amount of calcified pleural plaque. What's that going to be? Most cases, that's going to be asbestosis, but there are other things to take a look at or to think about in the differential. I don't want you to think every time you see calcified pleural plaque that it's asbestosis, because sometimes you'll actually get a decent history and they will have had no exposure to asbestos. So things to think about are previous fluid, previous infection, or pleurodesis. But typically you don't get pleurodesis on both sides. So asbestosis. This is a progressive pneumoconiosis. You know some of the other pneumoconiosis are like silicosis and co-worker disease. So what you're going to find in this entity is it's going to be a pleural-based problem. So everything is going to arise pretty much from the pleura, because you know that it's one of those, all the different fibers that are released from asbestos that settle into the pleura. And they're heavy, so they're going to drop. So if you think about what's going on in asbestos and think of the pathophysiology with those heavy fibers, they're going to drop. Gravity's going to pull them down, so it's going to be a basilar distribution, okay? And it's going to start with pleural findings. So you get pleural thickening. You'll get some subpleural findings like subpleural bands, and then those will progress into the round atelectasis that you can see as well. So we'll take a look at a couple of those pictures. So in this patient, this was actually the lung windows on that other mediastinal window, the same patient. So in this, it's you have some subtle honeycombing, some subtle reticular findings, and you don't really have much traction bronchiectasis. This doesn't occur as much as in the other entities like I had in the differential for ship doctors and stuff like that. So this is going to be much more of a pleural-based problem. So if we move into some of the other pleural findings, you can see these subpleural bands. You can see the thickening, and they start to creep along the subpleural margin of the lung. Here's another thickening as well. You can see the thickening on the mediastinal windows, and then a little further down you can see the subpleural bands. Those are all findings that you can say that there is asbestosis going on, because I'll dictate saying that there's no evidence of asbestosis, or I'll say that there are these findings and stuff like that. It's a big money game, so you have to. There's a big deal about this because of all the federal regulations and everything like that, and the trust fund made for asbestosis. We have a tremendous amount of asbestosis cases down here because of the power companies down here used to use asbestos, so we have lots of it coming about. So here is one of the later stages in the pleural disease, and this is the round atelectasis. Now, some people would think that this is a mass. I can't fault you for that, but this is pretty much a slam dunk case of round atelectasis. Look at what it's doing. Bronchogenic carcinoma or secondary metastasis don't do what this is doing. It looks like an onion basically in the coronal view. And what is it doing to the major fissure? It's curling around. It's retracting it. You get that swirling pattern of the vessels and of the bronchi. So really nothing looks like it, and I've never really been afraid to say that this is round atelectasis. I don't make people follow up on this. I just say what it is. But at some point maybe you'll get comfortable to do that as well. All right, its cousin. Let's move into silicosis and the co-workers pneumoconiosis. Now this is a little bit different, and I like to call it a cousin because it has similar findings, but it's in a different location, okay? The heavy fibers of the asbestos fall. Well, silicosis and all the inorganic minerals, the dust that comes from these things, rise, okay? They're lighter. So it's going to be in the upper lobes, and you're going to have impaired lymphatic clearance going on in the upper lobes to cause the abnormalities in the upper lobes. So It's going to be in a completely different zip code of what's going on. You're still going to have some architectural changes. You're still going to have some calcification, but it's going to be in a different zip code of, that's what I like to call it. So you have simple and complicated forms, which I'll show you a couple of pictures of, and they do have an increased risk of tuberculosis and pneumothorax. Now, instead of just memorizing that type of thing, I'm going to show you why, because it's easier to remember why you have these things rather than just to memorize it. So if you have impaired lymphatic clearance, you're not going to be clearing other pathogens. So TB lives in the upper lobes, okay? That's where the aeration is. That's where it's going to live. And if you have impaired lymphatic clearance, you're going to have increased risk. So pneumothorax is a little bit different. So what happens to the lungs with the pneumoconiosis? You're going to get the cicatricial scarring or emphysema, and I'll show you a picture of that. And that's going to cause a greater risk of pneumothorax. So here, this is a gentleman from Kentucky. He had a long history of mining, and he came in for progressive cough and dyspnea, and you can see that there's an upper lobe distribution in the coronal reconstruction there, and you have the architectural distortion and the emphysema. You can see the bullous changes along the major fissure there on the right, and this is pretty typical appearance of uncomplicated pneumoconiosis or silicosis. Now, getting into this other form here, on a different patient, you can see the cicatricial changes or emphysema that are peripheral to the progressive massive fibrosis of what these things are called. So I don't remember exactly what the cutoff is, 1 or 2 centimeters, probably 2 centimeters or something like that. When some conglomeration gets this big, they start to call it progressive massive fibrosis. So the cicatricial emphysema occurs peripheral to that, and if one of these bursts, you get a pneumothorax. So it's easier to remember the why rather than just memorizing the different things. You can see the bullous changes in the apices here as well. So moving on to the same patient into the mediastinal windows, you can see that in the area of the progressive massive fibrosis that you have areas of calcification. Now, it's not 100% diagnostic because they do say that bronchogenic carcinoma can engulf adjacent calcified granulomas, so it is possible that you can get calcifications within carcinoma, but one of the other things that you typically don't get are the cicatricial emphysema, and if you take a look at the lymph nodes down here in the hilum and in the subcarinal station, you get these calcifications. So I would be much more leaning towards a silicosis diagnosis rather than a bronchogenic carcinoma. And if you feel that you need to just throw that into the differential, you can certainly just get a follow-up. So that's what silicosis is. So moving into another area. Now this one is a little bit difficult. This is where high-res chest really kind of gets a little bit difficult, and you get your oh my god moments, what am I going to do with this? So in this patient, what do we have? Where are we? So the pattern, you can see the tiny ground glass nodules, and you can see them pretty much in the central areas of the secondary lobular unit. Now, I don't have any kind of cartoons. There's no outlining them. There's no pathology outlining them. You just kind of have to trust me on that. So, and where are we? We're at the mid-lungs, okay? So it's not not really high in the apices, it's not really low into the bases and stuff like that. So there is a differential to this. And in this particular one, this is the RB-ILD, okay? There is a continuum of this disease. This is smoking-related disease. So respiratory bronchiolitis alone, without the ILD, is actually quite ubiquitous. It's you see that a lot in smokers. It's just that there's no clinical ramifications yet. So they do have the bronchiectasis, or the respiratory bronchiolitis, I mean, not bronchiectasis, because of the constant influx of inflammatory things coming into the lungs because of the smoking. It's not until they actually have clinical findings or abnormal PFTs to start labeling them with respiratory bronchiolitis interstitial lung disease. So the continuum is you have the RB, then the RB-ILD, and then the second one, which I'm really not going to spend a whole lot of time on because it's not very common, is the desquamative interstitial disease, and that's kind of the end stage where you get some fibrotic changes and stuff like that, but that you're not going to run into that very often. So, and this is the most common lecture, so we're not going to talk about it much. So here is a live case instead of a textbook case, and live cases can be more subtle. So where are we? We're in the upper lungs. You can see the trachea. You can see the great vessels coming off the arch, and you can see the faint ground glass nodules, centrilobular ground glass nodules. And if I show you this next picture, you can see that they pretty much gradually disappear. So in the lung bases, you can see that there are no more ground glass nodules. So you know that this is going to be an upper lobe predominant pathology. So like I was talking about before, you get the pulmonary symptoms, abnormal PFTs, but there is a differential, and the differential is the acute hypersensitivity pneumonitis, the disquamative interstitial pneumonitis, which is more of an end stage, and you get, like I said, the fibrosis, and pneumonia. The pneumocystis can look exactly like this or variations of it. So having that in your differential, especially if you don't have any history, but honestly, if you get your HIV patients, it's pretty much a slam dunk at that point anyway. So that's the differential for the RB-ILD. All right. Moving into this next one, I thought this was just a fun little cartoon as a segue into this next entity, which is actually in the differential we were just talking about. So what do we have here? Pretty much the same thing. We're at the level of the mid to upper lungs. You can see the Y configuration of the pulmonary arteries. We're just below the level of the carina, so we're in the mid-chest. But what do you see? You see the same thing we just talked about. You see the centrilobular ground glass nodules, the tiny little nodules, nothing else. There's no architectural distortion, there's no adenopathy, no honeycombing, no bronchiectasis, nothing. So this is a location and history. All right, so this is acute hypersensitivity pneumonitis. And the key finding is your centrilobular ground glass nodules, and this is typically in a mid to lower distribution. Can you get it in the apices? Absolutely, I wouldn't discount it at all. But this is what the textbooks say as far as mid to lower distribution. Now, I went through 5 years of training at Botsford, and I had no idea what in the world head cheese was. It was just something that they said, hey, it's the head cheese sign. Cool, what's a head cheese? Nobody really knew. So I had to actually take a look at look it up for this lecture that I made just to be able to find out. And it's actually quite disgusting to think about. So I'm sure people love it in some regions of the world, but we'll move on from that. But this is a slice of head cheese with the different pork products and stuff like that. So the head cheese finding is seen because of the air trapping. One of the things that RB-ILD does not have is air trapping. So when you find the centrilobular ground glass or patchy ground glass opacities within the lungs, and you find areas of air trapping, you can start thinking about acute hypersensitivity pneumonitis. Now, what am I talking about air trapping? I'm talking about areas that retain the lower area of our lower attenuation, and again, this goes back to the secondary lobular unit. I said in the very beginning of the lecture, we're going to see this a number of times. Well, here it is again. You can see the geographic distribution of the ground glass opacities. So you see here all the ground glass, but then you have areas of lower attenuation where the air is actually trapped within the secondary lobular unit because of the inflammatory changes in the airways. So here is that head cheese sign. So how do they get this? It's caused by a lot of different things ranging from your typical farmer's lung, your bird fancier's lung. You can see it in malt, the occupation of using malts, mushroom growers, all kinds of different. There's like a laundry list of like 60 or 80 different things in different textbooks as far as what's going to cause the same imaging findings associated with acute hypersensitivity pneumonitis. Now, they talk about acute and chronic, but I like to say that, you know, just in the back of my mind, it's kind of an acute, subacute type of thing because you don't get this just with breathing, you know, the different organic or chemical type of exposures and stuff like that. It usually takes 2 to 7 years actually to develop the kind of changes in the clinical findings and stuff like that. And I would not typically put that in acute category, but it's acute in the sense that it's reversible. When you get into the chronic form, it's not reversible at that time. At that point, it's basically management at that situation. And compared to RB-ILD, smoking is actually protective in these patients. They actually develop somewhat of an immunity or a protection against the changes because they've been inhaling all the different chemicals from the cigarettes, that it's actually protective from the different exposures that they're getting. So it's kind of an interesting picture on that. And you can see the differential is pretty much the same what we've been talking about. Here is an inspiratory chest on the left. I'll get my arrow going here. You can see the areas of ground glass. And then here's an expiratory image here with the greater differentiation of the ground glass and the air trapping within the secondary lobular units. Whoops. Okay, now we've seen this before, and this is that mid-lung zone honeycombing and bronchiectasis, and this is again the chronic hypersensitivity pneumonitis. I just decided to show this again because this is you know, the hypersensitivity section. So again, you can get that chronic form. So hopefully I'm not putting too many people to sleep, and hopefully you're not feeling quite this bad, but trust me, we're getting to the end. We only have a few more entities to go. I personally like this version of it. I thought this was kind of a fun little Simpsons version of the same Salvador Dali picture. So, all right, trust me, we have just a couple more things. So, this last, or this next picture, we have some opacities within the lung bases bilaterally. And I'll give you a little clinical history with this, that the patient had a persistent cough and they were post-Avelox therapy, a bit of antibiotic. So what we have here going to the CT is we have consolidations. Where are the consolidations? Again, location. We're looking at a pattern. This is a peribronchiovascular distribution of these consolidations. So in a patient that you have this kind of distribution, you have the history of persistent cough, post-antibiotic therapy, you can start talking about the diagnosis of exclusion called cryptogenic organizing pneumonia. It's not BOOP anymore. I probably will drop that you know, somewhat soon because it's been like 10 years since I've been talking about it. But the key findings in these is exactly what we saw, the consolidations, and they can migrate. You see them in the subpleural areas, the peribronchiovascular distribution, the mid to lower lungs, and look at the differential. These are a lot of things that you don't want to miss. Okay, so again, COP is actually a diagnosis of exclusion. You have lymphoma, lung cancer. You can certainly get those bilaterally. I had a case just about 6 to 8 months ago of bilateral adenocarcinoma in situ, bilateral PEs. You don't see the infarcts very often like that, but it's certainly possible. And eosinophilic pneumonia is definitely a peripheral disease. So these are the type of things that the pulmonologists will probably have ruled out by the time they even talk to you, because a lot of them will come down and say, listen, I've got this patient, you know, I've given you the history, they're just not getting any better, their chest x-ray isn't getting any better, and so we start entertaining this diagnosis. Now, the reason why they actually get these consolidations is it's not because it's an infectious material, because it's been knocked out by the antibiotic. It's actually a filling of the air spaces by these macrophages and the inflammatory debris. So they cause the same thing because they're causing collapse. They're filling things up, just like pus and other infectious debris is going to do. But it actually can migrate, so you can see it a little bit differently in subsequent pictures, subsequent chest x-rays and stuff like that. So there can be a migratory appearance to it. So a couple of other different appearances of it, because it's not always typically one thing, like the peribronchial distribution, peribronchovascular distribution. You can see that you have the atoll sign out in the South Seas and stuff like that. So you have these crescentic appearances with the ground glass. And then here is the reversed halo sign. Both of these findings have been associated with cryptogenic organizing pneumonia as well. All right, we're getting in the home stretch. Last thing. Okay, so we have a chest x-ray with a whole bunch of junk in it. So what in the world are we going to do with it? Okay, so we're going to take the chest x-ray for what it's worth. So we have a bilateral, symmetric, coarse interstitial changes. Okay, does that help you? Absolutely not. Okay, nothing's going to narrow down that. Okay, but what you do find is with that green arrow, we have the costophrenic angle sparing. Now that ought to start ringing some bells as far as what's going on. So in this patient, the following CT of what I had is, unfortunately, the gentleman suffered from bilateral pneumothorax. That's obvious. But you have irregular cystic disease, and there is a differential to cystic disease. And it's irregular because it's not thin, lacy stuff. It's very ugly, really, as far as its description. You can see there's thickening. They're irregular. There's different shapes to it and stuff like that. And what is this ultimately? This is the pulmonary Langerhans cell histiocytosis. This is, again, a smoking-related disease, just like some of the other stuff that I talked about. Now look at the age distribution. This is completely different. Okay, the pattern's going to be different. The location is going to be different, and the age distribution is different when we're comparing it to UIP, or the usual interstitial pneumonitis. Now, what this, the bottom line of this entity is this proliferation of Langerhans cells, and these can go in a lot of different places. You can see them in the bones because you have eosinophilic granuloma. You can see them in the pituitary, all kinds of different places, and it's basically this proliferation of the Langerhans cell. It goes by all kinds of different names depending on some of the age distribution, like letter or seaweed in infants and stuff like that. But we'll focus on just the pulmonary findings as far as the PLCH. So what can we say about it? If you think about how it actually evolves, it will help you in determining the difference of the differential, what I'll go to in a second, is the evolution of pulmonary Langerhans cell histiocytosis is its nodular disease first, okay? Because one of the things when I was studying for boards is they always kind of asked about is it histiocytosis or is it LAM with nodules, and I always I had to memorize it because I wasn't understanding the pathology. But if you can understand the pathology, you have a much easier time remembering. So it's an evolution of nodules. They go to cystic disease. They cavitate, and cavitation is pretty much ugly. Okay, so it can have a nodule appearance that's going to slowly cavitate. That's going to cause irregular cystic changes with irregular margins and stuff instead of a nice lacy appearance. So it has the mid to upper lobe distribution with the costophrenic angle sparing. Those are all buzzwords that you might be able to think of when you're taking a look at the CT, or first off the chest x-ray, because it's so much easier to take a look at the chest x-ray first. You can easily get lost in the findings within a CT with this. I meant to go back. Let's go this way. Sorry about that. So the differential really kind of depends on the stage of the disease. So when we're talking about some of the things in here with the sarcoid, you can have all these tiny little nodules, just like I was showing you in sarcoid. You can have the tiny nodules in TB and also in METs. Okay. Now when you get into the cystic disease, you start thinking about this latter half of the differential right here as far as the LAM or just regular emphysema, or even IPF, depending on the appearance of what's going on and what kind of stage it's in. So let's contrast that with this. Actually, we'll show you one more picture here. You can see the thick-walled changes, the irregular changes. Here's some thin-walled parts, and it's very kind of irregular. So contrast that with this. You can see that this is much more uniform distribution. They're lacy appearance. They're all thin-walled. They can be irregular, but you can see that they're all uniformly lacy in appearance. And this is the lymphangiomyomatosis. This is going to be a similar age distribution, but look, it's exclusively white women. Okay, and this is going to be a proliferation of a different cell. This is a proliferation of smooth muscle, okay, not the Langerhans cell. So obviously that's not going to come up very often in a light box discussion or in an oral boards type of situation, but for people taking the written boards, that might actually come up. So other things that you can see in this type of patient is the persistent cough. They can present with the pneumothorax like my pre-test did, and if you have the opportunity to actually tap a chylus effusion, you'll be able to think about that as well. It is a very progressive disease, and I don't remember the exact lifespan, but it's not long, unfortunately. And again, uniform involvement. So let's just break this down just a little bit because I decided to do this because of the attention paid as far as the boards. So the similarities within these two different cystic entities is the cell proliferation. You have the Langerhans cell in PLCH, and you've got the smooth cell in the LAM. The age of the patients are exactly the same, the 20 to 40-year-olds, and you can have the initial presentation with a pneumothorax, and they get a CT because that's what ERs do, and you'll actually be able to differentiate what's going on as far as the cystic disease. Now the differences between the two is the histiocytosis is a smoking-related disease. If they cut out the smoking, they have a much greater chance of managing their disease. LAM is only seen in women, even though the age distribution is the same, and it's exclusively seen in women. In the histiocytosis, you see the nodules first, and that will help you differentiate things. And in LAM, you'll get effusions. It's very uncommon to have effusions within the histiocytosis. So that's pretty much the end of the most common diagnosis, but I want to leave you with a couple of take-home points. And the first is don't panic, okay? Like I said before, I have plenty of my own oh my god moments on what in the world am I going to do with this. I want to throw it back on in the list and make, hope that nobody saw that I'd actually clicked on it. But the only way you're going to learn the high-res chest is to actually suffer through it. So don't get discouraged. Take a look at some of the lesser involved areas of the lung and see if you can ferret out some of the patterns. So if you can nail down, just like we were talking about at the very beginning of the lecture, if you can nail down a pattern, if you can take a look at the location, is it subpleural? Is it basilar and peripheral? Is it predominantly upper lobe? That will help you narrow down your differential as far as what's going on. And always take a look at the smoking history, because there are different things that are predominantly smoking-related disease and other ones that aren't. Remember, the key role as far as being an imager is to answer two questions, okay? If you can answer these two questions, your pulmonologist will actually start paying attention to you, because you're actually doing him a favor and doing him what he or she wants you to do. Is there any interstitial disease? First and foremost, are you looking at normal HRCT, or are you looking at pathology? And if there's pathology, is it UIP? So those are the two major questions to answer in every single one of the HRCTs. Remember that there's a considerable amount of overlap. Just like I was talking about, collagen vascular disease is a common cause of some of the UIP and the NSIP, and just looking at the pathology isn't going to help you, okay? You have to take a look at the pattern and the distribution as well as the history to come up with your diagnosis or your impression, okay? Idiopathic disease is uncommon, and to fall back on the different things that I have listed here as far as the drug toxicity, the environmental exposures, especially when you're talking about the acute hypersensitivity pneumonitis. And then finally, all else, phone a friend. Okay, you can take that as phoning Google if you want to Google it, or if you want to do StatDX, or if you want to just talk to your colleagues. It's not unusual for me to just, I'm the only chest person in my group, but I'll actually ask some of the other people, it's like, what do you think about this type of thing? And sometimes their eyes will glaze over and I walk and find somebody else, but sometimes just talking about it with somebody actually helps. And actually, one of the other things that I do is, it's not unusual for me to get in contact with some of my other residents that I trained with, and we'll pass cases every once in a while and see what people are talking about. So phoning a friend can come in different different forms. So hopefully that you got some good information. Hopefully some of this will stick beyond next week about high-res chest and some of the common diagnoses. You will see these, guaranteed. You may not see too many of the cases of the later diagnoses that I talked about, but at least in the first half of the lecture, you're going to run into these numerous times, depending on what you end up going into, especially if you become a general radiologist with some other kind of subspecialty. But I'll have to say good luck at this point, and this is the end of the lecture.
Thank you very much, Dr. Johnson.
Is there any questions, or are we just sign off at this point? Oh, actually, if my email, if you can distribute my email, I was going to get that on the last slide, but I didn't put in. I'll entertain any kind of questions either through email, if somebody actually wants to, set up a time to call. I'd be more than happy to talk to anybody that actually has some questions about it.
Yeah, I can certainly include that on the email that will go out with the lecture recording.
Great.
Well, thank you again. We really appreciate it.
All right. Everybody have a great night.